The topic for this session is the role of generalist forensic nurse and advanced forensic nurse.
Maybe half an hour? Okay, I will finish in half an hour. So, very good afternoon to everyone. I think most of the people are sleeping in their rooms after the lunch, and it is very difficult to talk and very difficult to listen after lunch without going to sleep. So, I assure you, you will not go to sleep during my lecture. And today we are going to talk about generalist forensic nurse and advanced forensic nurse. So these are the terms usually, general forensic nurse we use very commonly. Advanced forensic nurse are, in India, we can call it a specialist nurse. Somebody is taking psychiatry, somebody taking different things. So this is just like one of the specialties is advanced forensic nurse. The situation in US and other Western countries is different, but what I am going to talk is about the Indian perspectives. Because the things are different, the laws are different, the requirements are different, and unless we develop the things as per the requirements of our country, we are not going to succeed. So I will be talking about that from the Indian scenario. Yes, what is forensic nurse and what is advanced forensic nurse? So forensic nursing science, we have talked in the morning what that is, and what is general forensic nurse and what is advanced forensic nurse, what does it convey? Call a nurse a general forensic nurse, and when we call a nurse an advanced forensic nurse. Then what is the role of the general forensic nurse and what is the role of the advanced forensic nurse in the Indian scenario? So this we had talked about the morning, that when everybody in these branches, forensic science, law, and nurse, they get the knowledge, and when that applies to the medical legal cases, sometimes even in the civil cases too, for finding out the solution to the complicated problems, for increasing the successful prosecution rate. And that is forensic nursing science. It has a big role in India. The whole space is open. This is a new specialty coming up. And all those who will get into it as soon as possible, probably they will be the leaders of tomorrow. Because those persons who come first, they will have better experience than the others who will join them later on. And people will see guidance from them ultimately. What is a general forensic nurse? So, such a nurse with the knowledge which a nurse will get graduation, she will have knowledge, but it will again depend on how much skills we can give to them. Only knowledge will not be sufficient. Skills are required, and you should see that they develop the skills. But the question in India is, first, the teachers need the skills in forensic nursing. So that is the question as far as we are concerned. Nursing educators. So we need to first develop the nursing educator system in India. So they can help in all types of cases, whether they are criminal or civil, or to protect the public health. So there are different types of the situations, but in India, what are the situations where the forensic nurse, general forensic nurse, can be of help, and where he can operate, and she is successful in that. So the role which I see in the future for the forensic nurse in India is in the mortuary too. The first thing, because all other departments, they have the nursing professionals in their department, whether it is pediatrics, whether it is surgery, whether it is medicine. But as far as the concerned, the role of the nurses is zero there. So there is a big area in the mortuaries. Mortuaries are all over India. And if you see the total mortuaries in India, probably that will be in thousands. And the poor condition of the postmortem examination is mainly due to the reason that there are no forensic nurses, there are no nurses, leave aside the forensic nurses, there are no nurses in the mortuary department. It is not that they don't want to work, but they have never been posted, and then they don't want to get posted. And some of them who want to get posted, there are administration hassles, and they are not get posted there. So in postmortem examination, then in the emergency, second part is forensic traumatology. In the poisoning cases, forensic toxicology. And in the sexual assault cases, their role in India will be different as we see from the USA. There, the sexual assault nurse examiners are there. But in India, for that thing to reach, we need to change the laws. Because so far, it is the examination can be done only by the doctor. So where the forensic nurses can get involved in that, so we will talk about that. In postmortem examination, where they can be helpful, receiving documents and the dead body in a good way, in a good manner, because these things are handled by just a PN and who is uneducated, or a sweeper who is totally uneducated, does not know anything. And probably that is the worst part, when a mother of someone or son of someone is brought to the mortuary, and how that is received, because those are the people who are receiving the dead bodies. So if the forensic nurse is there, probably the trauma to the relatives, that will be less, because they know communication is one of the skills of the nurse, and they will know that how to communicate in such situations. And it is not only handling the dead body, it is handling all those persons who come along with. Sometimes they are friends, sometimes they are unknown persons, sometimes they are just the passers-by, sometimes police officials. So different types of situations, different people bring the dead body to the mortuary, and they need to be handled carefully. Once they know what are the aims and objectives of the postmortem examination, once they know what is the procedure, how it is carried out, then they can be part of the team dealing with the dead body. And they can play a very, very important role here, that doing the things in a graceful way, in a better way. And once the reports are prepared, so usually sometimes doctors, most of the times, they are having their clinical responsibilities, and they are also doing the postmortem examination. So they say, okay, we have done the postmortem examination, but at least that time should be saved, which is concerned with the documentation, signing, and all that, and which is taking time. So the forensic nurses in India, they can do a good thing there. And the great thing is how that dead body is handed over back to the relatives. So sometimes the class 4s are handing over dead body to the relatives, and that is a pathetic way they handle. I must admit it. Being in this field since last almost 40 years, doing the postmortem examinations. And probably why I wanted to develop forensic nursing science in India was the reason that the way the dead bodies are received and handled. So I was not feeling good at that time, and I thought that if the forensic nurses are there, probably this thing will be very good. And first of all, I started giving them training in the postmortem examination room only to the nurses in my institute. when I was at Government Medical Patiala. And so how that dead body should be handed over? So dead bodies, they deserve respect. As a living person deserve respect, so they also deserve the respect. And sometimes the face is badly, and you can see the face on the left side. You can see the face on the left side. Is there pointer, please? Where is the pointer? Which one is work? Light, far light in this one? No, it's not working. It is not working. Give a side, please. I need a pointer. Okay, you can see that here how the face like. But if time is spent, we can reconstruct the face, and this is it is not working. Which one? This one? Okay. So you can see this side and this side, that this was the face. Usually the dead body goes back in that type of face. But when we brought nurses, told them, and this was, you see, this is the final shape which comes up. So you see, reality is, it is very disgusting for the family to see the face mutilated. So we can reconstruct the face. We can hand over the dead bodies in a good manner, can wrap them in a good manner. If the relatives want, we can give the proper dress. You see, a sick fellow, and we just put the dress as the family wanted. So this requires time, and sometimes the doctors don't have that much time. So this can be done. So when we are handing over the dead body, probably hair can be combed. Some good scent can be used so that it does not smell foul when the relatives are taking the dead body. So I see a big role for the forensic nurses in India in the mortuaries. Probably this is less in the Western world. And in emergency, there are so many victims of trauma coming. Again, this all needs documentation which can be done by the nurses. Evidence identification. So what are the evidences which can be good for the case? They need to identify that. Once they will be trained, they will know what to identify. And they will collect it, and they will preserve it. Identification, collection, and preservation, that is very, very important. And then handing over this evidence in a good manner to the police official. So that's important. So doctors are there, a team can be there of the doctor and the nurse, and the things can be done in a very smooth way. And finally, the handing over the documentation to the police, and a little bit of skill of identifying the injuries, what type of injuries these. So like this is a case where a husband used to, case of domestic violence, where husband used to hit the wife. So the injuries are there. So if they know, yes, this type of injuries are there, they can find out, yes, it is a case of domestic violence. So they need to identify the main things. So this is a case of firearm injury. They should be able to identify this. Because if they are going to the crime scene investigation, police official for which we are trying for the jobs, at least they should help something to the investigating officer at that time, and they should be able to identify the injuries. Yes, this is a case of firearm injury. And in the case of poisoning, again, as the cases of injuries coming to the emergency, similarly, cases of poisoning also comes to the emergency department in any institution. And again, the same documentation is required. Gastric lavage is being done, that is being helped by the nurses for the but doctors sometimes they are too busy, and this gastric lavage is never preserved. So the preservation of this gastric lavage is very important, which can be done by the forensic nurses at that time. And they can be they can get the skills for this. So again, getting the gastric lavage done, preservation of other evidence, you say poison bottle is brought or some can is brought or something is brought, so that. And handing over all this to the police, maintaining the chain of custody. Handing over documents to the police ultimately or whatsoever they have done, and communicating with Poison Information Center. Because as far as the treatment is concerned, there are thousands and thousands of poison, and treatment where all the poison is not there. Now there are poison information centers in India, and you need to communicate with them. So the forensic nurses who know a little bit of the poison, what type of poison is, they can talk to the poison information center, and doctor can go on for the treatment, and forensic nurses can provide the useful information to them at that time. So, like a case of snake bite, if they have seen, they will not forget it. So, how the things finally are given to the police, they are sealed. So, modern things have come, but in India, still we are continuing because the facilities are like this. Sexual assault cases, probably somebody is talking about the sexual assault nurse examiner. Sexual assault nurse examiner is good for the USA. But sexual assault nurse examiners probably may not be good in India because here the laws are different. It is the doctor who is to do it. But again, the doctors are in a hurry, always. And nurses, if they are totally dedicated for the sexual assault nurse cases, they know how to do the things in a correct way. And they are the great communicators as compared to the doctors. I think they are the better communicators with the patient, with their relatives, with everybody. They probably very courteously they treat the patients, and this skill can be used in these cases. So they can work in a multidisciplinary team. They can work in rape crisis center. In India, it is not the rape crisis center, it is one-stop centers. Centers are developing at all the district headquarters. Gradually, that will come to the Tehsil headquarters and at other places. So they can work there. They know what to do with the victims once they arrive. They know everything. And they can do it in a very good way. They know how to handle the relatives of that victim, because they are handling the relatives of the patients since a very, very long time. They know it better. And they have those skills. And of course, they're taking samples. They can always help, and ultimately handing over report and the samples ultimately to the police as soon as possible in a manner that chain of custody is not broken. And they are very good at psychosocial support, because such victims need psychosocial support in a very good manner, and that they can provide, which I think is missing when the doctors are going to do such cases, I have seen. So when we held a workshop for the sexual assault examination by a nurse and by a doctor, we compared that. The professor and head of one of our colleges, I will not name it, they said, what we had been doing for all these years, I think we were doing a crime. Now we know that how the cases are to be handled. So the nurses, when they are trained, so they will help in a great way in the Indian scenario in handling such cases. So in the morning I told that how even the minor injuries, they stain with the iodine, and then they get spray, and even the very minute injuries which cannot be seen by the naked eye, they get stained, and that can be, a photograph can be taken with the help of the colposcope. But again, the facilities we will have to provide, colposcope are there, but they are rarely used for this purpose. So there are different kits. We have Indian kits. So in my other presentation, there is Sahib kit, which we developed in India. And this is the kit which is developed in the South Africa. And since morning, so I was talking about this. And additional roles, what I have talked about, what the major role I see, in addition to that, they can be member of the investigating team at the crime scene. So this is the first place where I see many jobs for the forensic nurses in India. They may not get employment as a forensic nurse, but they will apply, they will be preferred, they will be taken as assistant sub-inspectors immediately. And this is a big change of roles. Once they are in the police in big numbers, they can demand and can have their separate role as forensic nurses. But initially, I think this is the way to enter the services when we have the forensic nurses. And as a member of team of the insurance companies always want to save money, and they employ other people. And when the forensic nurses they know what exactly is required, what exactly is not required. This can be cut so they can save the money of the insurance companies. And member of the legal team, and to the lawyers, to the advocates, so they can do the research for them, because lawyers have no medical background, they don't know anything. Nurses have the medical background, or you can say nursing background, and then they can research that and can help to frame the questions which can be good for their cases. Crime scene investigation, of course, very, very useful role, and I am stressing upon this, that the crime scene investigation can be done in a very good way. Probably the forensic nursing science that developed in the world, that developed from nurse working in the crime scene investigation and then shifted to the other places. And at the crime scene, what they can do, they will know the post-mortem changes after. They will know how much time does it take. They will be able to tell roughly the police officials at the crime scene that what time has elapsed, and in that way, the investigator will focus on the right persons. So investigation will become a lot better in the criminal cases involving death. So for example, there is a blood pattern. She can tell, yes, this is coming from the respiratory tract as sneezing or hemoptysis or like that. And when it is coming from whether it is coming from the veins or from the arteries, because the pattern is always going to be different. And it can tell about the relative position of the assailant with the victim. So all these things can be learned by the forensics, and that can help in the investigation. So anyone of you can tell the difference between these? What is this? So asking question gives you rest from speaking. Okay. So this was a case of terrorist who was cornered, and then he committed suicide with a firearm, and that was a rifled weapon. In this case, this was a case of homicide in which the smoothbore firearm was used. So at least at that point, they can tell the police officer, yes, this is a rifled weapon, this is a smoothbore weapon, and from how much distance this has been fired. Of course, ultimately, it will be the ballistic expert who will give the opinion, but in the investigation, initially, when nobody has any clue, they can give the clue. So, bullet and pellets and inside wounds, the cut throat. So this was a boy who was murdered with a sharp-edged weapon. So Narbali. So you know Narbali? Probably they will not understand. It is a sacrifice of a human being. So this boy was sacrificed because a lady did not have a son and she wanted to have a son. So somebody told him to kill, you give the sacrifice of somebody else's son and you will get a son. So the things happen like this in India, and you see the social and cultural aspects of a country you need to know as a forensic nurse too. So as a member of the team in insurance companies, we have already talked about, members of the legal team we have talked about. But in addition to this, the forensic nurses in India, they must know and they must talk about ethics. Because unless the forensic nursing profession is done ethically, it is of no use, or of very little use. Because if corruption is there, if something is being done under the influence of anybody else, because these are our problems, we need to understand that. These are not the problems of the West. The things are different. We have to develop the forensic nursing in India as per the needs and the socio-cultural aspects of India. We should know that, we should understand that, we should acknowledge that, only then it will be good. Law of the country, because these are different in each country. In USA, probably for the rape, the punishment may be very, very big. Here, it less, but now it has increased a lot. But still, it may not be that much as it is in USA. In USA, what is the punishment for rape? Yes. With the evidence? How much? Maybe 40 years, something like that? Not less than 35 to 40 years. Yes, we have the evidence, and without evidence, even they give sentence for 10 years. I know in USA, they give evidence for 10 years, even without evidence. The evidence, they go for 40 years. So it is something different in their context and in our context. And I always emphasize that in India, we need to develop forensic nursing science as per the requirements of India. We must not copy anything from anywhere. We should have the knowledge from them. We can have the skills from them. The application part should be totally as per the requirements of India. Yes, somebody in the morning was asking me whether the evidence which we will give in the testimony, which will be given in the court, whether that will be acceptable or not. No. Yes, you are professionals, and your testimony will be as good as that of a doctor. But you are allowed by the law, only if you are allowed by the law to do that thing. So, what experience you get, unless you apply it to the practical cases, almost zero results come out. So whatever you learn, you start applying wherever you get a job. So you learn that how to handle a dead body. You are posted in a mortuary. Please start applying those things so that the people find a difference. When previously a uneducated person was doing, and now what you are doing. But if you are going to do what that person was doing, or doing worse than that, probably forensic nursing name will get a bad name in that situation. So in India, abortions and criminal abortions that are not uncommon, we must have knowledge about that. Human in prisons, that is not uncommon. We must understand that. Forensic psychiatric nursing, this is a big area where the forensic nurses can play a very, very good role in India. And social forensic nursing, social things, social culture, crimes are there. We have different, like just as normally a sacrifice of the human beings. So, child marriages. There was sati pratha. There is female genital mutilation in some religions. I don't want to talk about that much, just giving you a hint. But these are the social needs, social culture things which we must know and which we must understand, and then we must do some so that these are reduced. These crimes get reduced. Or there is, if there is a crime, there is a successful prosecution of the case in that situation. Now, coming to advanced forensic nursing. Advanced forensic nursing is another certification for advanced knowledge and skills in a particular field. So these nurses have usually nurses have caregiving roles, but here the caregiving roles as well as the expert witness roles along with all what we have talked about. And role of advanced forensic nurses. So they become competent to practice keeping in mind the culture of the community. They are taught evidence-based practices to deal with different age groups of adults, old persons, and children. They have specialized skills. They have more knowledge. They are specialized competencies, and there is a credibility to that they will be the expert witnesses. Now, there is a big difference between other countries and in India as far as the expert advanced forensic nurses are concerned. Their sexual assault nurse examiners, they have advanced to a very high level in US. It has advanced in some other countries too, Canada also, a little bit UK also. But as far as the other countries are concerned, probably they are in that not much advanced. And in India, if we will talk about the sexual scenes, so their role is going to be different because here that cannot be done by a nurse. Nurse can a doctor in that case. That can be the part of the team in that case. And what she has done, she can give witness evidence for that. So such nurses provide holistic care to victims of any type of violence. And training is provided to investigate such cases, not just at that time, but throughout the life. Say, for example, person has been sexually assaulted. So you are done the examination of the victims. Now that after that is survivor, so you are dealt with the survivor of the sexual assault, and they are doing a good job in that. But it's the role, and there. Does it end after 1 month? Does it end after 1 year? Or does it after end 1 decade? No, it is never ending. Probably they will have some post-traumatic stress disorders. Probably 1/3 of the victims, survivors, they will never end with the post-traumatic disorders throughout their life. So this is to be dealt with. So in US, it is adult for separate advanced forensic nursing, and for pediatrics, there is a separate advanced forensic nurses. They are there. So probably somebody is going to talk about, so I'm not going into details because the next speaker is going to talk about the sexual assault nurse examination, so I will not encroach upon that topic. So if you want to go in the US and do the advanced course, probably they require BSc in nursing, 2 years as a registered nurse, 40 hours of classroom training and sane clinical preceptorship, 300 hours of sane practice within the last 3 years with set numbers of hours, observing court cases, riding with local police enforcement, and patient care of survivor of violence. Probably that is in that country. You want to go to US and get some good degree there and come back and serve back your own country. Probably very few people are doing that. But if some people do that, that will be a, you see, can adapt to the Indian scenario later on. So I think the advanced forensic nurse, which I have talked in the beginning, a general forensic nurse, probably all of those branches, whether it is in the mortuary, whether it is a crime scene investigation, whether it is in the emergency, or whether it is helping the attorneys, or another insurance companies, probably the time will come when all these courses will become as advanced forensic nurses in India. So this is, I am talking about 10 years or 20 years later, right from now, what I am talking about. Just like in 2002, I talked about forensic nursing. So in 2022, I am talking 20 years ahead that those things will be gradually coming to India and get into any of these branch, and probably you will be successful as far as your career is concerned. So again, I will like to repeat, Any one of you interested, become member of the Indo-Pacific Academy of Forensic Nursing Science. Probably a few have given their interest, and I'm very happy. And I am very happy that if they work for forensic nursing also along with me. And then when the nurses will become the leader, probably, then I will consider that I have gained the success what I wanted to achieve in my life when the nurses take over the role, the role I am playing today. So that day I will consider that I am happy, I am successful, what I had thought 20 years back. But still I need many of you to come with me and be the leaders in this group. And we have plenty, good number of cases, and 249, but I think with this conference, at least I want that it's 10 members of you, 10 from you, must become the members for this academy. Just 1,000 rupees as a life membership fee. We are not taking money from you every year, but this is a lifetime, and you get many benefits. So be the member of this academy, and thank you very much. Yes, probably I will like to request to chairperson that what concept you have, probably that is yours, that's not mine. What perception I have, that is mine, that may not be yours.
No. I think that was a wonderful talk. I will be the next speaker to carry on with Dr. Goria. I think he finished with a wonderful vision for the future, and you know that's coming very quickly. 2 or 3 years to be certified at different levels is going to be wonderful. So let me, why don't you, any more questions? Or concerns, or thoughts, or sharing. I'm going to talk to the students in the back now. So when you think about being out in clinical practice or your patients that you've met, has there, of course, if we talk about this here, we don't use patient names or hospital names or towns, but is there any situation that anybody has had clinically with a patient where you thought or you knew there was domestic violence or sexual assault involved? And if you did, I'm assuming this has happened, do you have a sense of what you did? Do you remember what you did about it? Did it feel, and how did you feel when you started to ask the questions, you as nurses? Would anybody like to share? It doesn't have to be formal, just, talking like a story of a patient who came to you and you were concerned. You had those light bulbs going off in your head. I wonder if this person was assaulted. Would anybody like to share? I'd love to hear from the students, and don't be shy. Well, how about I'll give you time to think about it, and I will revisit that question at the end. Okay. Do you want to take more questions? I don't think there are any more questions, do you? No. So is it when I'm the last one? No. I don't think mine's going to be that long because I have. It's great, yeah. Go to the third one. Go to the third one. Oh, I have to use this. Okay.
Are there any queries? Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you, sir. Now for the next session, Sandra Friedman, Clinical Professor, College of Nursing and Health Professional, Drexel University, Philadelphia, Pennsylvania, will be taking the next presentation.
Yeah, so I'm going to have a shorter version. It's late in the afternoon, and I'd like everybody to keep your attention. Yeah, excuse me.
Thank you, ma'am.
We're calling people to sit.
So, chairperson for this session is Professor Samriti Arora. The ma'am is currently working as professor cum principal at College of Nursing, AIMS Rishikesh, recognized as PhD nursing guide at INC, and has work experience of more than 20 years. Ma'am has BSc Nursing, MSc in Pediatric Nursing from College of Nursing, AIMS, New Delhi. PhD in Nursing from INC. Madam has co-certification in traditional Chinese medicine in China. Ma'am had worked at Amity University, Haryana and Jamia Hamdard. Ma'am has been honored by Indian Academy of Pediatrics for her contribution in basic newborn care and resuscitation program. Ma'am has published over 2 books and has more than 250 citations for her publication in various national and international journals. Ma'am has participated as national trainer for COVID-19 pediatric care, NRP HIV/AIDS, and national mentor for nationwide quality of care network for quality improvement under Lakshay and Muskan program. We welcome you, ma'am. Now I request our resource person, Professor Sandra A. Friedman, ma'am, to kindly begin with the session.
For the second chairperson, I would request Dr. Sunita Verma, ma'am, to please come on the stage.
Okay. Again, I'd like to thank everyone here, the students, first and foremost, of course, Dr. Devinda, Dr. Neelam, Dr. Goria, and all the students and faculty. Can you hear me? No. Do this one. I'll do this. You can hear me now, right? Okay, thank you to all. First and foremost, Dr. Neelam, Dr. Devinder, Dr. Goria, all the faculty, visiting faculty, colleagues, and students, welcome. Again, it's been a long day, so I am going to move through this quickly. But first and foremost, we've talked a lot about sexual assault, and we've seen pictures, very specific assault, such as if someone comes into an emergency or emergently in a clinic. That's kind of the obvious. That's the obvious. We see obvious physical issues and psychological issues at the time. And we know the patient will say, I've been raped, or they come in for care. But I'm going to go broader right now because we all know that at any age, men, women can have domestic violence, can be sexually assaulted, but they never tell anyone, right? And they carry that. They know that when they were younger, they were touched inappropriately in some fashion. They never say anything. And this is a lifelong trauma that many, many, many people carry. Why? Because of the intense shame, the shame involved. So I want everyone here, the students, I'm reaching out to you to understand your role. When you see, like this slide, and this is in the United States, we have an exam for and certification for a sexual assault nurse examiner. And from what Dr. Goria said, I think you'll be seeing this type of certification here. But as for right now, what value, what can you do on on daily encounters with your patients and families, what can you do? What do you ask? How do you find out the underlying traumatic event when the patient has said nothing? You know, so you have a golden opportunity each and every time you meet a patient, at the undergrad level and at the graduate level. And first and foremost, I'm big on this. I'm big on assessment. But what does that word mean? That means taking the patient's history, getting to know why they're there and what they've been through. We can do that in many ways, in short visits. Oh, this, I don't know. I don't use this. We can take that history. But I'm going to give you two of my favorite Referral professional techniques that I use with every single male or female patient. I always ask questions that this spend at least 5 minutes with my patients alone. When they come in, I'm a nurse midwife, so I do see patients for gynecology, for birth control. I also see pregnant women throughout pregnancy and deliver the babies and postpartum. I have many opportunities to be with the patient, but not always alone. Oftentimes, if someone's been assaulted or there's violence in the home, the person, the boyfriend, the husband, or a female partner will come into the session, right? And say, and the woman will say, I'm here for this. I'm here for something else. I'm here because my rib hurts me. And she didn't come in saying, I've been assaulted. She came in with a rib hurting her. You still take a history the same way. You ask the, name, age, and why are you here? Oh, I'm here for a broken rib. But as you ask more and more, you still might not get to the fact that she's been physically assaulted, sexually assaulted. Because the partner is sitting right there. So I always say to all my patients, every day, I always and I announce it to the partner or the friend or the relative, I always spend 5 minutes with my patient alone. So you may, if with the patient's consent, you may stay here, but I'm going to ask you to leave towards the end of the visit so I can have some one-on-one time. I say that to everybody. And so many times in my life, during that 5-minute time, that's when I find out that they've been carrying a lot of guilt, a lot of shame, and they have had sexual assault. So that's a pearl. And if you have the opportunity, as you become more advanced in your career, to have a few minutes, that's really important, because people and patients will not always tell us because of shame, in fear that if my partner finds out, I'm going to go home and get beaten up again. So that's a pearl. And my second question I generally ask in all histories of any woman and any man, I say, do you feel safe? Do you feel safe where you live? Do you feel safe in your community? That critical question about safety, they may tell you, no, I don't feel safe, and you might elicit something in your history right there. So that's the history. It's very important. Many of you may think, well, I'm not there. I don't know a thing about this. I don't know what to do. We don't have a certification yet. It's not important to me, but it is important because it's a key component of a history taking of every person. So when you ask a medical history, a surgical history, you always do allergies, family history. When you get to gynecologic history, you can ask about history of sexually transmitted infections, of course, but it's all together. So I look at this as a very important assessment skill, your history taking. If you don't ask the right questions, you don't get the answers, and it does trickle down the path into your exam or the physician's exam, because they're not looking for it. If you don't ask if someone was sexually assaulted or could they have an STD, sexually transmitted infection, up in the beginning, when it comes down to this point in time, you may not do a certain swab or a swab of the throat from having oral genital sex. You might not do it because you never asked the question. You never thought, well, and this has happened to me. I've learned over the years. I also want to say that there's many settings. It's not, we talked about this, and a doctor referenced this at the very end. Just because you're a forensic nurse, you have that cap on, but where do you work? It doesn't always have to be in our country, or I assume here, a sexual assault identified place. You will screen people for all of this in a family practice, like a general physician's office, an internist, or in our country we have advanced practice nurses with a nurse practitioner. I'm a nurse midwife, so I see a lot of pregnant women before and after. I always include these questions in my exam. You can be a pediatric nurse practitioner and still have, when it's time, the forensic nurse certification. You still can work in pediatrics. And you're the resource, you're the heavy resource in your hospital setting for assault issues. But you still can work in integrated ways and integrated practices. So I think I'm very happy that everything's evolving, and all the work that you put in, it's arriving. And it's so wonderful to have everyone participate. I'm going to go through these slides quickly. In the U.S., we have a certification for a sexual assault nurse examiner. And basically, we focus on, we know that we're compassionate, we give physical safety, we tell our patients that we will respect confidentiality, we give that special time alone, we have a high regard for our patients when they're vulnerable, we don't cast blame, even though we might have a moment where we're critical in our head. That's us, and we create the boundary to always ask and behave ethically. Like Dr. Goria mentioned, ethics is huge. We behave ethically and protect our patients. Now, the same sort of thing with a rape victim, what I just mentioned. In the U.S., and potentially, it looks like it's very close on the radar here, for a SANE certification for a nurse, if you treat and want to treat only adult or adolescents, in our country, over 18 is adolescents, your certification hours are 120. If you're a pediatric nurse practitioner, and you want to focus only on those younger, you have a pediatric SANE program, 72 hours, and then there is a non-reporting avenue for 120 hours. So this slide was shared with me from a friend and colleague in Oklahoma. In this particular year, that clinic saw adults with sexual assault 350, pediatrics 80 to 100, and non-reports 30. Now, a nursing response depends on your resources in your area or in the clinic. You can directly, if it's affecting someone's physical status and it's emergent, you can certainly call for a dispatch, a police dispatch, depending upon where the patient is. And I'm going to go very quickly right now. And these photos are similar to what Dr. Goria showed, the different exam rooms, a bathroom with a shower. It's a very specific place often in an ER or family clinic where these exams occur and interview is taking place. So again here, we talked a little bit about this. You want to take that history and never, never go slow on your history, because that's where you get a lot of information. Also, during the history, you're establishing a rapport with your patient, which is critical. You're establishing safety. You're using your therapeutic communication techniques, such as, oh, you mentioned this, can you tell me more? Can you tell me more? That's therapeutic and it's open-ended. So you get a lot of information in that history. And you take a medical, surgical, family, obstetrics, gynecologic. You may need to obtain swabs to provide evidence that the patient was sexually assaulted. But I'm not sure in this country if only physicians do the swabs. In our country, physicians certainly do, but in an advanced nursing role, the advanced practice like pediatric nurse practitioner, women's health nurse practitioner, midwives, family nurse practitioners, all take swabs, and they can be from, as I mentioned, oral swabs, the oral pharynx in the back of the throat. There's can be oral genital contact, and STD can be in someone's throat. We typically think we're only doing a penile or vaginal or cervical swab, but no, we need to think of other areas of the body that could have had penetration or unwanted touch. So the oral route I mentioned, the genital swabs on the outside of the pubic area and also inside the vagina on the cervix, and the anal region can also be a place for swabbing. Photographs are important, of course, better than video. I mean, a video you can lose it. Your photos tend to stay. Your documentation is very important. And then referral for medical treatment, depending upon if you have resources in your clinic or you refer to a forensic nurse or a specialist. Also remember here your follow-up. Mental health follow-up, counseling, resources for social work, if you have those available. Really assess what's available for your patients in the mental health arena. And you do this all the time as nurses. When someone has had a sexual assault and there's any potential that a pregnancy occurred, in our country, I'm assuming here, we have something called emergency contraception. It's Plan B. So this could be a very young adolescent girl with no intention of ever having pregnancy, being sexually assaulted with penetration, and in this case, she comes to you, she's with her parents. We offer emergency contraception, which is medication to stop an egg meeting the sperm. And I'm assuming you have this here. In our country, it's over the counter in a pharmacy. Also, during any sexual assault, always think of sexually transmitted infections. STIs or STDs. ST, sexually transmitted. And common ones that are there's more than these. There's gonorrhea and chlamydia, which are monitored and taken by a cervical swab. So that's when the woman will have gently a speculum put inside the vagina, slightly opened, and a swab is taken off of the cervix, which is about 2 inches from the opening to the outside. So we do swabs for two infections, chlamydia and and gonorrhea. And also swabbing the cervix for a pap smear generally. We'll check for any evidence of HPV, human papillomavirus. But in addition, the swabbing, and I think you know this, is not just the only thing we do to rule out sexual transmitted infections. We take patients' blood work. Does anybody know, in terms of screening a patient for STD, what blood work you would do? How about students in the back? Have you had this yet? Any of this content? Can someone speak up for me? Don't be shy. I'm trying to figure out, I'm trying to get a sense, have you seen patients that have had unwanted intercourse or a sexual assault? Has anybody ever and had to work with a physician, you assisting, getting swabs, drawing blood? Any of the students? Not yet. Okay. So when you do, you're going to remember, and this is the importance of being well educated in this topic. Because you as a nurse can say, well, yes, you took a swab of the cervix and you're going to send it off to the lab to get tested. But you speak up then and you say, well, what about the blood work for STDs? And the typical blood work is an RPR. It's called on the lab slip, RPR. It's a test for syphilis, which is a sexually transmitted infection. And you can also do a herpes blood work test, type 1 and type 2. Can also needs to be swabbed. You might say, well, why would I think of that? Well, unwanted contact in any way, you certainly can get all of the infections I just mentioned: gonorrhea, chlamydia, genital herpes, syphilis, and HPV. We're getting a little complex, a little bit deeper now, but understand this. You know what you've just heard. Tomorrow or the next day, you might not remember all of this. I'll be happy to send out the slide pack that I'm using if you'd like to take a look at it later, and it has some references. But the important thing I ask for you to understand conceptually what I need to do. I need to really get a good history, and then when I go to the physical exams portion, I'm really going to analyze all the parts of the body that may be affected, and number one, test for STDs. You may not know exactly everything I say, and you haven't had experience yet, but you know one thing. You know what's possible, and that's where you go to your great resources, your most up-to-date textbook, an evidence-based model relating to STD collection. You go to your resources and look it up. Make sure it's evidence-based. So in this case, you become more educated. You become more educated with physicians as they round. This is vitally important. You become a frontline, and someone, speaker, mentioned that today. We are the frontline people. So we need to really think that through. And I have a little bit now on the critically injured patient, meaning, and we talked, this is a patient who's assaulted, maybe even strangled or killed, but right before they're sexually assaulted. I'm not going to read through everything because we've had a lot already today. So part of your job as a nurse, if you're not advanced and you're still learning, you contribute to the physician that you're working with or another nurse practitioner. Speak up with your thoughts. Learn, because you're in a learning environment. Here's a bit more about the kit. We know that there can be drug or alcohol-assisted sexual assaults, meaning they prompt the perpetrator to do more. We talked about toxicology testing, and here's some forms. Photographs. Film is cheap. Opportunities are full. Well, the best way is you can take a series of photos, though. All right, let me go quickly through this. So evidence collection, you'll see this when you start working in this area. Photography first, don't touch anything. Take pictures, use plastic bags, brown paper bags, or that are unused. One item per bag. Air dry, don't put wet things in the collection box. Use binding on your envelopes, and have a chain of custody. What does that mean? The chain is of where is your specimen collection going? Do you leave it outside the door? And I've seen other nurses do this. You just leave it out, hoping that the lab or whatever come pick it up at night because they're supposed to and they never did. So be rigorous about your collection and have a chain of custody, meaning who is responsible for managing the specimens, taking them, sending to the lab, but also who is responsible for finding out lab results and carrying on. There are non-reporting times that the patient does not want to report to authorities, but still we do a lot of counseling and still do the STD checks. this was mentioned a little bit before also in terms of your risk factors in screening. Don't forget, look at the way your patient is acting. If your patient I'm talking very rarely makes eye contact, they're looking down, they're looking to the side, they're obviously shamed, or you get a sense that they may be hiding something, they may really want to tell you at that point. So now that's your golden opportunity. But on another slide, there were some very important kind of precursors or kind of warning signs or red flags that you can say, I hear that. It might be a sexual or related assault or domestic violence. So you can ask your patient more in depth, have you ever felt afraid or fearful? Have you had any genital injuries or unusual bleeding? If they tell you that they've been assaulted, you can understand, do they live with this person, rare contact or unknown. So you keep the patient's clothing and undergarments, of course. The gluteal cleft, that's on your buttocks. The line right at the bottom of your buttocks is called the gluteal cleft. That's an often missed opportunity to take a sample collection, right? So I want you to think about swabbing there if you're a member of the team. And another place that you can swab for evidence is our belly button, the umbilicus. And as I mentioned, drugs and alcohol are a big part of all of this. Going fast. The collection kits we've talked about. I'm going to make these slides available to you so that I'm not too repetitive here today. But again, reporting. When you have an adult, it's up to the adult if they want to seek out full specimen collection and make a formal report. Some of our patients do, and some do not. And that's their choice. However, in our country, I don't know the rules or the laws here, as Dr. Goria mentioned, we work in a law-abiding country. If you're under 18, you don't make those decisions. I mean, the provider in our country, such as me or a physician, is obligated and mandatory to report this to the state if there's been a sexual assault or unwanted touch with a minor. We're obligated reporters. Now, the other certification in the U.S. is a domestic violence nurse educator, just to tell you. And this, again, is a very big public health issue. Homicides are often, as Dr. Goria mentioned, so I'm not going through all of this, but a big component in drug use with sexual assaults. There's a lot of overlap here in the bigger picture. Victims, the perpetrator, the law enforcement, police are called, and then healthcare providers in a hospital or clinic setting. Here, I'll give you this slide, but here's a great resource for a patient that you want to screen for intimate partner violence. Again, it's very hard for a woman or a man if their partner is sitting there. This can be two women that are partners, two men that are partners. It still can be very difficult to say you have violence against you when your partner's sitting in front of you and you live with them. So always create that kind of sacred space. Identify, these are things that you can pick up, nonverbal indications of violence. Or sometimes even when you have no suspicion, nothing comes up in the history. If you see any of these things when you're interviewing your patient, lack of eye contact, hypervigilant partner that won't leave the room. I've had this in my life several times. It's like not normal that the partner wants to stay. Even when I ask, I want to spend 5 times with everyone alone, they don't leave. That's a big red flag. It doesn't mean diagnostically your patient has been assaulted. But up here, it's like ding, ding, ding. That's a potential. Any injuries. For example, I had a patient once who had domestic abuse and violence in her home. She was being beat up. She was pregnant too. And I think you do know this, but I'll mention it. During pregnancy is one of the highest rates of physical violence, domestic violence, very high. She would come in and tell me she would fall down the stairs all the time. She came with bruises. She was not falling down the stairs. She was, but that's what she told me because she was too embarrassed to tell me anything else. And she was being pushed and hurt and punched by her partner. So injuries that are unexplained, like a repetitive broken bone, a black eye in someone. It doesn't mean definitely, but a black eye, how'd you get that black eye? Those are things that we need to be thinking of. Inconsistent explanations. The patient responds one way with a typical part of a story, and then later on it changes or it's inconsistent. The patient may appear to be very anxious, short responses. These things are very important to think about. Injuries that you may see with any physical violence in the home or out of the home, right? And this is not someone coming into the ER saying that they've been raped, but what you will see in a clinic you might see injury distribution around the body. You might have an eardrum rupture from someone's head getting pushed on a wall. You might have a genital or rectal injury, like the opening, the introitus of the vagina is torn or a rectal area is torn. That's not typical. Cigarette burns over the body is another flag. You think, how could that be? I've seen them. It's a coercive measure to get someone to act. Any biting marks? Yes, humans can bite other humans. Patterned bruises, they're typically in the same spot. And repetitive injuries with different stages of healing. History, these are all the red flags. None of it means definite, but now that you know, I expect you to be really good history takers and then go on to the exam and see if what you heard in your history connects to any physical assessment findings that you have. Red flags, drug or alcohol abuse, someone that has been delaying seeking treatment, injuries, as I just told you, during pregnancy, injuries that show a defensive posture, so you get bruises on your upper arm on the patient, any suicide attempts, obvious rape, evasion of questions, embarrassment, lack of concern about injuries. You see a lot of injuries, you're trying to get this information from the patient, and they're pretending, oh, no big deal, I bumped into the wall. But you see it again. That's another red flag. Or minimization of injuries. So this is just another little scheme that shows the diagnosis. So you can write as your diagnosis potential sexual assault by partner. Doesn't mean it is. And you go on to document accurately, do all the physical assessment and history taking, but then in the P part, the SOAP note, the subjective, objective assessment and plan, make sure there you order, or the physician, you tell the physician you're working with, because if you're not in a situation, I want you to know though, I want you to know to say to the physician, well, I think this patient could have needs blood testing for STDs. So you want to document, and in the plan, you communicate well with the physicians, and or if you are the nurse in charge and you have the right certification, you must document all your lab work, all your swabs, but also there in the plan, you highlight and say, discussed with patient, emergency plan. If they felt very unsafe in the house, they need to know where a woman's shelter is, for example. And we saw lots of resources offered here. Or in the plan, you document what you educated the patient about. Your patient may have known nothing about STDs. You can write out, I educated and explained that I did this testing and what we're going to do for follow-up. And part of your evidence, of course, and part of the legal chart is your photographs of what you were concerned about and any evidence collection that I mentioned in terms of clothing. So that is kind of, wrapping up. There's a lot more involved, but I think as growing nurses and developing leadership roles and educational roles and clinical roles in an advanced practice setting, I want you to think like what I told you, think very organized as subjectively what your patient is telling you. Objectively, what are you finding on physical assessment related to what you heard subjectively? Kind of be that investigator always. This isn't just for one kind of patient. This is for men, female, this is for everybody, every single day. You should be having this in your head. And then you will be a change. You have forensic nursing skills. I encourage you to become a forensic nurse if you're interested. You will still be able to work, for example, in the ER, but you have those skill sets and your nurse leader will know and refer those cases to you when you're there. So it's an integrated model, but you would need to learn, like Dr. Goria said, all your basics first and practice. Stay in an interdisciplinary team with physicians and physician's assistants and nurse practitioners. But I want you never to shrink. You need to speak up for your patients. And you help your other team members in this way too. Physicians are very helped by nurses, very. I've had very experienced physicians and very experienced midwives make mistakes because that's the name of the game, where we can make mistakes. So it's really great to participate in care and communicate well with your team. So I'm going to wrap that up right there, but any questions for me? Students in the back that would like to share a story? No questions? Yes. Thank you.
Good afternoon, ma'am. Good afternoon. Actually, I do have two queries. The first scenario is, sorry.
Can you, anybody fix this? I think we should turn off one mic. Can you, what? Oh, okay.
Good afternoon, everyone.
You can use it now.
Actually,
Yes.
I do want to clarification on scenario. One where the girl or the boy do not want to reveal that event, where they do not want to want us to explore the event or sexual assault anyone have done with them. And the second scenario is, I do feel that this forensic nursing is the most affected area where the political powers and the authoritative powers do some different events. They do not want to reveal that victim part. They want that the victim cannot reveal the things, and that event will not come out. So how we can deal with these two scenarios where the victim do not want to reveal the event, and second is how to overcome that political as well as the authoritative part in these cases, especially in sexual assaults.
Well, the first part, maybe you can help me figure out the question. I think the second question was, what do you do if the patient, they've been sexually assaulted, they know too, but
Yes,
they
ma'am.
don't want to report?
Yes, ma'am. The first scenario is where the person do not want to report the scenario. We know that she or he has been assaulted sexually, but they do not want to reveal because in Indian scenario, this is the worst taboo a person can have.
I know.
Because it is very difficult to live with this taboo that he
Is
has been assaulted sexually.
Is this someone that you took care of personally? This is like a case study that you're telling me about?
I have seen many documentaries, but personally, I haven't met any person
Well,
in person.
It behooves, I mean, it helps if you know the patient and they've seen you a few times. That is really helpful because then you create more safe space
Yes,
by
ma'am.
inviting that back in. You might not be able to encourage reporting or whatever the first time around, but you can say, you know, we talked a lot about today. Thank you for sharing. I will keep this confidential. Why don't we connect up in 2 weeks and then give her or he another opportunity to come in. But in our country, you can't force reporting. Only if you're under 18, there are what we call mandatory reporters, nurses, teachers, healthcare workers, nursery school teachers. That's mandatory. Even if the parents say no, it's still mandatory. But I don't know, I haven't had the experience in this country. Has anybody? You can't force a patient to go. Dr. Goria, do you agree?
So your question was that people don't want to report. Yes, that is right. But the cases are being reported, that is just the tip of the iceberg. Most of the cases are not being reported, and till the cases are reported, we can't do anything.
Right, so Dr. Goria said in this country, a lot of things go as an iceberg. You know, the iceberg has a little bit of ice on the top, but the huge, bigger that can destroy a ship is underneath. Well, to that underneath level. But I think creating rapport.
So that is making the people aware that they should not be afraid. Let them talk about the things, because if they remain silent, then they are not helping the society. They are rather promoting that such more attacks should come, because once the person who is culprit, he is not punished, he doesn't go to the jail, then probably another victim, and another victim, till some victim comes and talk, and that person goes behind the bars. So we need to give education to the patient that they should talk. It will be better for the society. That's what I think.
Thank you.
Maybe sometimes it will be re-traumatizing. Yes, sir? It will be re-traumatizing. So we have to be, as sir said, we have to be tactful in talking, as sir throughout his 2 presentations has dealt with the counseling with a lot of skills. So they will only reveal their problems when we will be good counselors. We will ensure them. We will develop trust. We will try to be like their own. We will be able to guide them. That otherwise, if we are not skillful, it will be re-traumatizing. That's why they will not be revealing the truth.
I wanted to add to this also that our legal system is weak at the moment in India when it comes to assault cases being reported and treated. Like for the case of Aruna, it has happened in front of me, and I was in the same nursing college and the KM hospital when we were undergoing a training program, and till the death, we have taken care, the nurses have taken care of her, but none of the health team members came forward to help us. So it's very traumatizing to see such cases live in front of us during a period of services. So as this topic is coming up in the future, I think we nurses should strengthen it up more so that we realize it in our education system first. Unless we don't take it in our education system, the administration will not work on it.
Correct.
So that's important.
Correct. I did concentrate a little bit more on the history and the exam. Is this working? Yeah. A. Remember, we're never exist with a community of police investigators, all the members of the healthcare team, all the nurses, our staff. It's a big number, right? So we're never just do one thing in isolation. I did concentrate a little bit on the lecture, but this is big. A big part also, which you mentioned, is your referral network. If you work in, let's say, an ER or a very big clinical practice, you will have a network, whether they're there in the building or in the community, of social work, a mental health person, a pediatrician, others to reach out, and you develop your network as a nurse. Oh, okay, thank you. Anybody else? Other questions? How about from someone in the back, a student, any clinical cases that you were concerned about? I'll share one really quick one, and then I'm going to say goodbye. This was an example of a young woman that I was taking care of. She was a minor in U.S. law. She was under 18. She came, I was the director of an adolescent health center. She came in. Why did she come to me? Because her pediatrician saw something on the outside of her genitals, the vulva, and said, oh, go to the clinic and see Sandra. Because guess what? I can only guess he didn't want to deal with this, but that's why he sent this young patient off to a pediatric clinic. And when I examined her, I would say 99.5%. I mean, I didn't have blood work at the time. I didn't do a herpes swab, but it looked like outside genital herpes. Her mother was hypervigilant, right there with her the whole time. So I did what I told you. I asked her mother in a very polite way. Oh, with everybody I see, I always keep 5 minutes at the end so I can have some one-on-one time. So the mother left the interview room, and I looked at the patient. She's only 15. I said, I was direct. I said, have you felt safe in your home? Quiet, no answer. Has anybody touched you inappropriately in your genital area? She did not respond, but you know what she did? It was her body language. She was looking at me, and after I asked her that question, she put her eyes down and looked at the floor. So I did, genital herpes swabs, sent it to the lab. I did blood work for type 1 and type 2 herpes, which can tell oftentimes if it's a very recent or old infection. And guess what? I told her maybe a week and a half would be ready. She came in with her mother and father this time, sat down, and wanted to know the results. And the father, on the first visit, the mother told me also, oh, no, everything's fine in our house. But you know what she said? My husband has herpes on his mouth. So, I didn't have evidence, but I'm putting the pieces of the puzzle together. The pediatrician probably knew this young lady had herpes, but sent her to me because he didn't want to deal with the parents. Because I'm a mandatory reporter under 18, I had to report this incident. And it's not easy to do, but I of course I had to. Because in my mind, my suspicion was she was being sexually abused with probable oral contact on the external genitals. And I navigated that, and I did have to report. But that's just an example of, technique and what we need to do to protect our patients. So let me sign off here, and we'll all be here for questions after.
Thank you, Ms. Sandra, for that very clear presentation. Yeah. So as Ms. Sandra has very clearly taught us today, that it's very important to have very respectful communication whenever the patient is entering to your clinic or your department. So from the first year itself, we all are taught then how we are supposed to talk with the patients. But as we grow older and older, I think we forget that. Now, since I am working as a principal somewhere, so I hear these type of comments that the nurses are not talking properly. And this special complaint we get generally from the male nurses. Many of the HODs, the directors, the administrators, they will come and say that you need to give them training regarding the communication skills and the soft skills. So whatever you have learned during your basic education, during your first year, don't forget that. And this is a very sensitive topic regarding to sexual assault. You know, sexual assault can happen to anyone. Big child, elder people, male, female, rich or poor. I remember when we were going for some program, quality improvement program in Trivandrum. There we went to gynae OPD and we asked them, the doctors, that what are the problems in your areas? And she told us that in those areas, the poor girls, the laborers, no, they are coming and they come and they tell that they are being raped by some rich, influential people. Okay? Then the doctor tells them, okay, now you make a complaint, you do all these things, but they don't go further because the matter is resolved within both the parties. The richer people, they will give them some money and then the whole thing is shut down. So that is the ground reality. So maybe because they are not well educated, but if if this type of happenings are, this type of incidents are happening with some more educated people, you can come forward. So we should not shy away. When someone comes to you and reports to you, you have to deal with them very respectfully. You have to take proper action. And people will reveal their details to you only if they feel comfortable. You have to talk to them in a very non-judgmental manner. So make sure that you are dealing with your patients in a very sensitive manner and you are talking to them very, very politely. Thank you.
Yeah, Madam has told everything clearly. And the most important thing is confidentiality. If we are maintaining confidentiality, so definitely they will explore everything to us. As one student has questioned, they people are not revealing that something has happened with them. So confidentiality and communication skill is very important. So we need to remember this all when we are dealing with such patients. Thank you so much. Thank you, ma'am.
Thank you, ma'am. Thank you, chairpersons, Professor Simriti Arora, ma'am, and Dr. Sunita Verma, ma'am. Thank you. Now the next session, Ms. Suman, ma'am, will introduce the speaker.
So the next topic of the evening is trauma-informed care, guiding principles addressing mental health, well-being and self-care. And this topic will be discussed by Professor Mahmooda Regu, Professor cum Principal at Alamdar Memorial College of Nursing, Medical Technology, Islamic University of Science and Technology, Avantipura. Madam is BSc Nursing, MA in Public Administration, MSc in Community Health Nursing and PhD. Ma'am has received Florence Nightingale Award in 2008. Ma'am was Executive Board Member of Nursing Research Society of India. Ma'am was Organizing Secretary in National Congress of Nursing Research Society of India, President Steering Committee of TNAI at J&K, and has also contributed in re-establishing TNAI at Jammu and Kashmir. Ma'am is also a member of many societies like Nursing Research Society of India, Life Membership, Indian Society of Hospital Administrator, Voluntary Health Association of India, Central Health Education Bureau, Government of India, Swasth Hind. Ma'am has participated and presented research and review paper in more than 100 national and international programs. Ma'am has published in indexed high-impact national and international journals. Ma'am has received more than 40 research papers and over 45 textbooks on manual of sociology for nurses. We welcome you, ma'am.
Chairperson for this event is Dr. Rafiqa Bashir, ma'am. Ma'am is principal in University Institute of Nursing. Ma'am has MBA in Hospital Administration, MSc Nursing, specialization in Medical Surgical Nursing, MA Sociology and MPhil in Sociology, Doctorate in Philosophy from University of UK in 2012. Ma'am is also having postgraduate diploma in NGO management and hospital management. Ma'am has merit of being associated with many prestigious organizations, specifically Dr. NTR University of Health Sciences, Vijayawada, RUGS Bangalore, NIMS Hyderabad, MUHS Nasik, and MNC Mumbai, and also organized and participated in more than 100 national and international conferences, seminars, and workshops. Ma'am is having membership of TNAI, Nursing Research Society of India, Indian Association of Critical Nursing, and many more. We welcome you, ma'am. And second chairperson for the session is Ma'am Dr. Jyoti R. Tiwari. Ma'am is officiating principal at College of Nursing, Chandigarh University, Punjab. Ma'am is BSc Nursing, MSc Nursing, specialization in Medical Surgical Nursing, MBA in Hospital Administration, Master of Business Administration, MA and MPhil in Sociology, Doctorate in Philosophy from Prescott University, UK. Ma'am is also having postgraduate diploma in NGO management, postgraduate diploma in hospital administration, master diploma in business administration management studies. Ma'am is coordinating with local and state government system, CBOs, voluntary organizations, Panchayati Raj institutions, and NGOs and community services. Ma'am is assessing the training needs in coordination with district teams and supporting organizations, plan of trainings from each year, monitoring various training programs and their evaluation. Ma'am managing the project proposal development, representation and implementation, having contact with various schools and colleges of nursing in India, as well as various NGOs in Goa and other states in India. Ma'am is having membership with TNAI, Nursing Research Society of India, Indian Association of Critical Nurses, Society of Community Health Nurses of India, Indian Association of Health Administration, Clinical Research Society of India. Ma'am has attended more than 35 national and international conferences, seminars and workshops. We welcome you, ma'am. Now I request our resource person, Professor Mahmooda Regu, ma'am, kindly begin with the session.
Good evening to everybody. Good evening. Nobody is sleeping. So, when we'll see trauma-informed care, my topic, trauma-informed care, guiding principles, addressing mental health well-being and self-care. So, it has couple of things there. So if we will see this, for whom we need trauma-informed care. First trauma, what is trauma? It is any event which can happen to anybody. It can be man-made, it can be natural. Trauma, I will call it a disaster. So it can be done by some human being, or it can be because of some natural thing. So trauma-informed care, it understands and considers the preventive measures of trauma and promotes environment of healing and recovery rather than practices and services that may inadvertently re-traumatize. So we have to see the trauma, what is trauma? It is sudden, unexpected and perceived as dangerous or life-threatening.
it is overwhelming individual's ability to manage that situation. Then DSM, you understand, DSM is Diagnostic and Statistical Manual of Mental Disorders. As per the American Psychological Association, it see somebody, somebody is with post-traumatic stress disorder, it addresses that. So it can be anxiety disorder, and it includes trauma and stress-related disasters. And trauma, it can include direct experience of any traumatic event, as I said. Then it can be witnessing the trauma event in a person, learning that trauma event occurred to a close family member or close friend with the actual or threatened death being either violent or accidental, or experiences first-hand, repeated or extreme exposures to adverse details of traumatic event, not through media, pictures, television or movies, or unless work related. So it is a definition of the trauma. Various forms of trauma, as people have been talking about traumas since morning. It can be sexual abuse or sexual assault, severe neglect by their own people, physical abuse or violence, war, accident and injury, serious medical illness. So chronic illnesses and the illnesses with somebody will be perceiving that illness will kill, that also can traumatize the patient, like all oncological diseases, all life-threatening diseases. Then deprivation caused by extreme poverty. So when they are not able to meet this ends, and they are not sure of 3 square meals, they can be also traumatized because of poverty. Then gang and drug-related violence can be there. Some people are induced drugs, so there can be drug-induced problems also. Then some people are oppressed, they are kept in imprisonment with no reason or with reason. Then witnessed violence and cruelty to others, though emotional and psychological abuse, and repeated abandonment of what is TIC? Trauma-informed care. It is it strengthens, it is a strength-based framework that is grounded in an understanding of and responsibility to impact with the impact of trauma that emphasizes physical, psychological, and emotional safety for both care providers and survivors, and that creates opportunity for survivors to build a sense of control and empowerment. A manner, this trauma-informed care, it is a manner of interacting with clients. So it's a skill with the assumption that they have experienced trauma. And trauma, as somebody said, they don't want sometimes to reveal what all happened. This ensures that all communication, and some of our experts, they were talking of the communication skill. So all communication is less likely to trigger. If we will talk in an unskilled way, that may trigger the thing and they will be more worse than they were. They will be with more stress. So it should not trigger the negative response in clients while at the same time conveying safety, care, and respect. So we as healthcare workers, we have to convey safety, care, and respect for the clients. We don't have to trigger the event by our less skilled communication. So we have to be very, in this informed care, we have to be very particular about talking to the clients. Then we have to work to establish relationship with people who may have been humiliated, hurt, or betrayed by those who are supposed to be counted as for safety and protection. Sometimes we are nowadays listening, father did this, this uncle did that. So that is more traumatizing if somebody abuses somebody whom they are expecting that they will be their caretakers and who are caretakers. So this TIC, it recognizes the prevalence of trauma, assessment and treatment for trauma. It focuses on what happened to you. What happened to you? It is a narration. It is a narration that they will be talking as it is, if they will believe you, not what is wrong with you. So we have to, this is the communication, we have to talk to them, that is what happened to you. It is not what is wrong with you, because nothing is wrong with them, the incidents happen. So all of these things are supported by so much of the research nowadays, because so much of the traumatized events are happening. So in TIC, they have to recognize their coercive environments are re-traumatizing. So we don't have to talk again and again. We have to talk only when we need it, and we don't have to talk in an unskilled way, and we don't have to talk to others that this thing happened with them. So we have to be very particular to gain the confidence of the victim. So recipient is center of his or her own treatment. So we have to talk the treatment to the survivor. We have to empower the survivor.
Talk to them about management of themselves. That is how they can prevent themselves from re-traumatizing.
We have to be transparent and open to outside parties. So we have to talk to outside people that survivors. It is none of their fault. As somebody was talking in the morning, that those who are criminals, they should be focused, not the survivors. Survivors should be supported and they should be empowered to take self-care. So you have to say, you don't have to keep power and control with yourself. You have to give power and support to the survivors. Staff, as staff nurses or this nursing students, we have to train ourselves so that we will be understanding what has happened to them, why they are behaving like that, so that we will take them out of that situation. So we have to focus on collaboration. We don't have to engage in interactions that are demeaning, that are disrespecting, dominating, or coercive or controlling to the survivor. We have to respond to disruptive behaviors, like we have to show empathy. Empathy, and sometimes sympathy will not work. Sympathy will make pity, sympathy, that will make the person to think very low about themselves. So we have to empathize, we have to feel as they are feeling, and we have to be compassionate with the survivors, so that we will have very good this listening skills. We don't have to talk only, we have to listen a lot, and we have to listen to their questions, and we have to find the solutions with collaboration with the survivors. So some of the common principles of trauma, informed trauma care are, we have to understand the situation. That is, through knowledge and understanding of trauma and stress, we can act compensately. As I said, compensately is more than emphasizing. So we have to be very good to them, and we have to take well-informed steps towards their wellness. We have to we have to involve the surroundings. We don't, so that they will be accepted by the people, they will be accepted by the family, they will be accepted by the surrounding people, and they will accept them that it is none of their fault. I have seen, I will tell you, one of the AIDS patient who got AIDS because of this blood transfusion. Then when he was talking, and others, other people in the surroundings, they were talking, see, he is not ashamed of himself, he is an AIDS patient, see what he must have done. So it is, we have to listen to the patient, we have to find the cause, and we have to see it is not none of the survivors' fault, it happened because of the other things. So you have to see the healing value of traditional culture connections. You have to recognize and address this historical trauma. You have to see from previous experiences also what has happened to him, how you will make him or her to adjust in the present scenario. Then safety. The next principle of the TIC is safety. You have to see, feel physically and psychologically. You have to make the survivor physically and psychologically safe. Not only the survivor's family also, you have to ensure safety in terms of thinking and in terms of adjustment. Then trustworthiness and transparency. You have to build a good relationship with them. You have to maintain trust in these participants or your survivors, then family members, and your team, other members of the team. You have to do power sharing in a meaningful way. You have to make mutual decision making. You have to have authenticity and consistency, whatever you will be doing. You have to, it will not go in one talking or one session. You have to be consistent in talking. You have to give so many sessions so that they will come out of the trauma. Then about choice, you have to analyze the strengths or strong points, experiences, and of the survival, and you have to build upon them. You have to make them to relax so that you will be able to building upon their experiences, upon their strong points. The experience of having the voice and choice, that you have to validate. You have to use new skills, so that you have to be innovative in developing skills, so that you will be able to help them in de-traumatizing. The organization, any of the organization, you have to foster resilience in them. Resilience means, what is resilience? That is, they will be coming out of that shock. Your communication, it is not you will be giving medicine. Your only communication as nursing students, you have to help them in coming out of that situation. So you have to be advocates for them. You have to show advocacy skills, so that if others are talking bad about them, you have to make surroundings also experience that nothing is, again and again say, nothing is wrong with them. It is because of the situation what happened with them. Then about the collaboration and mutuality. So you have to recognize which way they will be healing, what way, what relationships we will develop, what meaningful power decision making we will be doing, sharing. So that is how we will be collaborating. That is the principle of collaboration and mutuality. Then empowerment. Empowerment, see, we as students, we are empowered by knowledge. So like that, we have to empower them with the facts. What is the factual situation? So when we are talking of we will be talking to them as it is not, it is what led them to the situation. It is none of their fault, so that they will first accept themselves. Then same thing we have to talk to the family, same thing we have to talk to the surroundings. so that we will be empowering them. We will be in a very voluntary way, we will be having first compensate relationship, we will be empathizing with them, so that we will be in a voluntary way, we will be empowering them. We will not use judgmental approach. We will not use that is somebody because of she went in the night, that is why it happened. Or it is not because she wore this type of clothes, it happened. So that way, or she was talking to boys, that's happened. So these things are judgmental. So we have to use non-judgmental approach when we'll be taking care of we will be empowering and taking care of the survivors. We have to have, every situation should give them respect, and every situation should reciprocate. That is, I should tell them with love and compassion, so that they will feel strengthened because of my only talking to them. Then we have to be, again I said, empathetic, and I use the word compassionate with the survivors, so that they will be strengthened, so that they will be empowered. Then these are the principles in this one go, that is safety. You will be ensuring physical and emotional safety of the clients, families, and the community, because one cannot live alone. We have to live, we are social animals, we have to live in the society. So we have to ensure what happened. It happened because he or she was not in the fault. So we have to deal with the common areas, and we have to respect the privacy of the person. Choice, we have to, the individual has choice, and that is, sometimes they will not be able to talk. When they will be in the intense situation, they will not be able to talk. We don't have to compel them to talk. That time we have to just, if they want to be quiet, we also have to be quiet. Maybe next session will be when they will open up. Maybe that is now it has happened. They don't want to talk. That is the choice. When they want to talk, you will give them choice. When you want to talk, yes, you can come tomorrow. So individuals, you have to provide them a clear and appropriate message about their rights and responsibilities. That is, right of myself to expose to you, right of myself to tell everything. That is my right. So I can say, this time I will not tell, maybe I will tell about 4 or 5 days afterwards. So that is your choice. Then about this collaboration, making decisions with the individual and sharing power. That is, you will be collaborating with the survivor, and you will be sharing your power. What is your power? Your power is knowledge. So पहले ही मैंने कहा कि, see, it is the value system. If we will believe in God, psychology hai, it is open thing. If we will believe in God, we sometimes tell them it was to happen. You cannot feel, you cannot go back. This has happened. Now you have to adjust. That is the strong point. So you have to collaborate with them. This has happened. Now you think of your survivor. Death is not decision, or some harming yourself is not the decision. Now you have to survive. It is not your sin, it is sin of somebody else. So that is the collaboration. So you have to, as individuals here are the survivors. They are provided with significant role in planning and evaluating services. So based on the collaboration, they will be developing trust on you. That is, one of your teachers said, so some people don't talk about their happenings. So why they don't talk? Because for that they have to reach to different milestones. That is, you have to be trustworthy for them, so that they will believe in you, and they will tell everything, and they will feel safe, and then catharsis will happen. Then catharsis, their burden will be, it will just go. So they will be believing in you. That is this trustworthiness, task clarity, consistency, and interpersonal boundaries. So you will have respectable and professional boundaries maintained between the survivors and the caretakers. Then empowerment. You will be prioritizing empowerment and skill building. You will be seeing how we can empower. We can empower, well, we will make them understand. First thing, it is none of their fault, because there is guilt in that. They should not feel guilty. Providing an atmosphere that allow individuals to feel validated and affirmed with each and every contact as the agency. So everybody, we all have to think of empowerment of those survivors, the clients. Then about what is this TIC? TIC as a process. Healing happens in relationship. Main hai iska. So in TIC what we do, we understand the prevalence and impact of trauma. If we will see trauma in different individuals, this is different. Some people are more sensitive, some people are less sensitive. But some people, because of their personality, they come out of the trauma quicker than others. So it depends upon the personality. So understand the prevalence and impact of trauma, how much it has happened to them. You promote safety. I says it is safety means you will tell them the aspects and you will make them to understand that it is not their fault. And you will earn their trust. When you will ensure safety, they will be trusting you. And you embrace diversity. So you have knowledge about each and everything, so that you will be inculcating subject knowledge of different subjects, so that you will, and also you will be keeping in mind people are not same. There are individual differences, even not identical twins are same. So you will be embracing the diversity in healing the patients with your relationships. You will be providing holistic care. Maybe there is trauma, there is stomach upset, there are other systematic problems. You will be, we as I say myself as a nursing students, we will be providing holistic care to the patients. So we will respect the human rights. We all know, because of the constitution, because of religion, because of other things, we know what are the human rights of the people. So we will be respecting the human rights. We will pursue the person's strengths, choice, and autonomy. So as I said, there are different people with different strengths. Some people are weaker emotionally, some people are stronger emotionally. That will help them in healing. So you will have to see their strengths. Then after seeing how much strong they are, they have to give them choice. You have to make them independent so that they will be able to heal. You have to share power. Your power kya hai? Maine abhi bola. What is your power? Your power is knowledge. Your power is knowledge from diversity, from different subjects. So you will be sharing power. You will be making them powerful by your knowledge. Then you will communicate with love. You will communicate with compassion. You will communicate with trustworthiness, so that they will be able to understand you and they will be able to trust on you. That is the healing happens with relationship in TIA. Then addressing mental health, well-being and self-care. Identifying and validating feelings. People who have experienced traumatic events, particularly at the hands of, I again say, significant caregiver, were given contradictory messages, dismissed, ignored, silenced, abandoned, blamed, shamed, told that they have no rights to feel, etc. So you have seen that people who are traumatized at family, they tell them not to share this with anybody. That is why they don't share it with other people. So if they will not share with other people, then they will go to a post-traumatic stress disorder, and some depression and other psychosomatic and psychological and psychiatric disorders, which will not, they will not be able to heal, they will not be able to come out of that situation. So you have repeated opportunities to offer corrective experiences, but they should tell, that is, sir has given numbers, so they should tell there what has happened. We have seen some I have seen 3 sisters, I have read about 3 sisters, then they were molested by some priest. On this care, they will be, their father and mother, they will be rich. Mother was helping them to molest their girls. Then first daughter, she could not reveal her what is happening with her. Then second daughter, when she saw third daughter, who was a teenager, she also is molested. Then she went out and she went to some woman group and she told everything about that, this sadhu. So that is what we have to give awareness to the people, so that people will not be culprits of priests and others, and those people, even I said their own parents, So we have to save this girl child. Regulating feelings, a significant outcome of having an all-well nursing. So we see, we have emotional dysregulation if we are not we are not treated as we have rights. So this can make it harder to use skills learned in the past. So any psychosomatic things can happen. So we have to regulate emotions by talking to the people. Whatever, even small things. People nowadays say, Me Too was, so much Me Too was there. Hai na? You all have heard. Some they were inappropriate touch, some were talking that thing. Even males were talking of Me Too. So when something like Me Too happens, so that you should reveal. If it is even inappropriate touch, you should reveal. It should not go beyond that inappropriate touch. That is, you have to regulate, you have to tell whatever has happened, you have to tell at least to your close friend. So that only you will be able to share, you will be able to protect yourselves, we will be able to protect all others. Understanding the stress response. Again, we as healthcare workers, we know that nervous system, most important function is to keep us alive by alerting the danger. We know if we are very vigilant, we know what we will be observing people, what is in their hearts, what they can do next. So we have to protect ourselves by that also. Many people are under and over responsive to even the slightest perception of danger. So that helps us in prevention of the violence. That helps us to prevention of this disaster, or that helps us. We have to be somehow suspicious also. Being over suspicious is again a disease, but we don't have to blame unnecessarily on people. So we can protect ourselves by being conscious at every step. Then identifying and managing triggers. So again, I will quote that this faculty who was talking, they are not exposing their facts to us. It is sometimes even that scent, जिस इस माहौल में उनको वो चीज हो गया, even that smell, that feeling, that activity, that body sensation, it can re-traumatize them. It can again traumatize them. So we have to give them time when they will be talking about what has happened to them. These are survival-based memories and can lead to seemingly inexplicable reactions. They can re-traumatize and they can be bad to worse. Then reframing symptoms, problem behaviors, and coping strategies. The price of living through adversity. Like they have to live with, they will be again and again memorizing anxiety. They will be feeling numb. They will be feeling restless. They will be feeling different. And they will be, sometimes they will be just forgetting, flashbacking, night. They cannot sleep. They will be having everything in their dreams. They will have nightmares. These problem behaviors, we have to tell them about the feelings. There should be some expert in psychology, those who can tell them about actual situations. We can be their advocates. We can be with them so that they will not be going to depression, or they will not be going to euphoria, or they will not be going to other things. So sometimes if they are euphoric, we have to calm them down. If they are depressed, we have to elevate them up. So responding to trauma disclosures. Many events that cause trauma are highly stigmatizing. So it's a bichara, bichari, hai na? So we say so many things about Me Too that has ruined the life of so many high-fi people. So that is, but those people who have revealed their Me Too, they are stigmatized. So people become accustomed to keep secrets, believing that they were somehow to believe, because people will anyway, they will believe them, they blame them. That is, the others knew what has happened and what they will judge them. Then that judgment and happening will damage the person, and that is again what we call re-traumatizing. Having one story heard by someone who is supportive, again, it is the kind of this re-traumatizing ka ulta hai. If you are supportive, if you are skillful, if you are compassionate and you are willing to listen, it can be a healing experience, and they will build trust on you, and you will be able to help them. That is, most of the times these are the clinical psychologists, and some of the clinical psychologists are not that. Clinical psychologists with good skill can make them to cope, and we can work as having good relationships and taking history, and maybe sometimes they will not be able to reveal everything to them, and we will be able to reveal, and we will be able to tell their facts, so that we work as their advocates and help them in gaining trust in us, and in helping them in coping with the situation. Open and respectful communication with the survivor. Many trauma experiences are dehumanizing. So that Madam Neelam has given the case that is dehumanizing. That is leaving people feeling shame and internalized judgment. They are judging themselves. Judgment or clinical language may reinforce these beliefs. This language also allows staff to put clients in another category. X, this person is very different for me. This type of distance may prohibit the information of the therapeutic or healing relationship. We as caregivers also sometimes, what we do, it has happened to them. We talk to them like, yes, it has happened to do. So if we will tell them what has happened, and then we will help them in somehow in feeling safe, then that way they will be feeling, that relationship will be like therapeutic and healing. Then setting appropriate boundaries. People with histories of interpersonal relationships, trauma may have physical and emotional boundaries violated. So again, I say sometimes neighbors, sometimes parents, sometimes uncles, sometimes their own people, they are violating their trust. So they don't then trust anybody. They will be, even by simple talking, they can be traumatized. People who were supposed to be trustworthy have committed incomprehensible acts. That is again and again, as I said. So we cannot set boundaries. So set very rigid boundaries, and as well they will be not able to say, he is my father, he is my brother. Nowadays stories like father by brother are also coming in this newspapers. So they will not be able to believe anybody. They will not be able to set boundaries like they will protect me. Like that, it is very difficult for us, for caregivers, to take care of those people who are whose assault is by their own people. Most of the times they isolate themselves. So that is how tactful we have to be in this care. Then self-soothing and stressful management. It is extremely difficult to change habitual ways of dealing with stress. During a crisis, people revert to old ways of coping. Pre-identify accessible tools are necessary to change old patterns. So nowadays, so much of research is available about every individual. Maybe some individual story is same as the story of this individual. So you have to do a lot of homework. You have to do a lot of literature review, so that you will be seeing, is there any story like this story, so that I can help the client, I can help the survivor. You have to go to appreciation. So this, because again and again, it is none of their fault. You have to tell them they are in pain, they are in danger, but this pain and danger can be distracted and redirected, and you can remind them of some, that is diversional therapies, fun, security, belongingness, joy, going out, then seeing the beauty of the nature, and humor, so that you have to use other diversional therapies, so that you will be able to help them in coping. Then reasoning for being, you will tell them it is, there's people who live with an onslaught of pain and loss begins to question life's meaning. Life appears hopeless, disconnected, and without response. So you have to, again, nature happened. Again, you will be reason for being, happened. Now you say another step, you have to survive. how you will be able to survive. You have to tell them how to survive and how to cope. That is the fun of this. Then you have to tell them to be like hummingbird, resilient. You have to be resilient. You have to come with the adjustment. That is all. Thank you very much.
Hello. Hello. Good evening to everybody. Thank you, Dr. Mahmooda. She has managed her topic in a short time. She has taken all the aspects of trauma, then in self-care and the principles and other things she has dealt in detail. And she has not left anything, I think, for us, but just to conclude, I think I must add little bit regarding my personal experiences about the trauma. And as she said, the trauma is a destruction. It can be from a disaster. It can be from a terrorist attack. It can be like an insult with close personal relationships. So this trauma, if we will talk of, nowadays, the elder people, the old age people, they have 70% of the trauma. Now the reasons behind it are their isolation. The limited children, when they are working in abroad, they are left in isolation. So when their death comes, the last days comes, nobody is there to take care. And that is the, many reasons are there. And if we will talk of terrorism, the terrorism in our place, you know, is so high, and a son, the mother sends the son to purchase the vegetables, and on the roadside, he gets a fire and is dead. Now you just see that mother who is expecting a son with vegetables, but gets a dead body. So how you are going to console a mother who has lost her son on the way for shopping? There are many examples of such trauma which is not going out of our mind. I will give you my personal experience. When I had COVID, nobody was there to take care. I was in isolation, and my son was out of home. Out of home means he was COVID negative. He used to bring us something to eat, and the shopkeepers were not giving him the vegetables. He was not provided milk because he is the son from the affected family. So how much trauma is there due to these small things, which is very difficult to tell to the public. Like the other example I will tell you, a girl, a teenager, is raped on the way while going to school. So how can, when they informed the police tell her, you narrate the whole story. Is it possible to narrate that story to the policeman? So that is why there are many crimes, there are many sexual assaults which are not to the public, known to the public, because of this condition that she will have a bad name, she will not get a good match. So there are many things which traumatize, especially a lady, a woman, a mother. So I thank Mahmooda ma'am. She has given all the principles, the 6 principles. That means we nurses, when we heard the stories of many victims, we ourselves get traumatized. We get post-trauma stress that is very difficult to come out. So as nurses, we say when we deal with such programs, the awareness programs, the laws and other things, we have the coping ability to take out. So this is about the sharing about the trauma and self-care. So when we say self-care, first we have to give care to ourselves, then we will be able to listen to the others. So we nurses, we should be brave, we should be encouraged, and we should come to the forefront as we dealt with the COVID. So I'm sure we can also deal with these such assaults going ahead. Thank you very much, and God bless you.
Good evening, everyone. It's a well said about the topic what we were talking about, the trauma-informed care. And I think it's gone more into depth. We have heard a lot about what was said, how one should handle with it. And I would focus more on the teaching part of it because we are from the education field as well as from the clinical fields also. Now, all what was mentioned over here, if we put it a little more into our evidence-based practice, the trauma-informed care, it would be well sound and more ethical for us to understand how deep we can go into the screening part and the assessment part, and how we can handle the patients psychologically, as well as the other side when we are in the education field, how we can train the students. Now, there are certain things, what we see mostly is it has a gross impact of physical and psychological here, and then it also has a long-lasting effect. It does not go. So there are a lot of things like, even if a person has experienced trauma, there is a post-trauma stress disorder. It remains a stigma in the society. Again, we come back to our own subject of community health nursing. We have learned sociology. We should know how to handle these cases in our day-to-day life when we are practice nurses. Also, there are a lot of potentials where we need to know what are the clinical referrals. These are a hands-on skills training experience, what one needs to know. We are learning psychiatric, we are learning mental health nursing, we are specializations, doing it in the post-graduations. We should know in depth how to take it forward in our system of nursing profession. It's not one isolated subject, but definitely it should be incorporated. Last not the least, I should add that with the current scenario and the nursing informatics coming into it and forensic nursing coming into our syllabus for nursing students, we have also been inculcated about the NEP 2020 program. That is the policy set by the Government of India. This transferred trauma-informed care is come into a value-added course where we all nursing institutions should take up for our students so that they can understand from the initial stage of their education life, and when they choose their career, a path in the nursing profession, they are well established to handle any cases that come to them. This is all my information to you. Thank you.
Thank you, chairpersons. I have read a lot about, as madam was talking, evidence-based about trauma-informed care. But I have seen all individual cases, it is different. So we as nursing students, what we have to do, we have to do everywhere, we have to do a lot of research review. Whenever we will see a case, we have to, as I said during my talking, we have to find where is the case like this case. There are hundreds, thousands of stories about trauma-informed care. But the thing we have to see what is related to this individual by which we can help them. So we have to always we have to develop habit of this relating the things with the evidences what are available, research-based evidences, evidence-based practice, so that we will be helping them. That is, it is a very sensitive issue. All of us, we cannot talk. We have to, I said, sometimes we have to just be silent. We don't have to talk anything. We have to only listen. If they are on the other side, they are just not talking. We don't have to. We have to see. We have to set another counseling session so that they will be just telling what is in us, what has happened. So that is how we have to deal human beings. It is not only trauma-informed care, it can be any depression, it can be schizophrenics, it can be any, it is a mental health scenario. Now, this process recording you must have heard, you must have dealt with the patients who are not even talking, something or the other thing. So it is not only this trauma, sexual assault we are talking, we are sometimes seeing child's development, but final development takes place within 5 years. Then we are, most of the times we are going out and leaving our child with a maid, and some maids are making them to take this banana ka chilka khilate, banana khud khate, and they are beating them you sleep. So those also can be the battery. That also can be traumatizing, and that traumatization of 5 years, that comes afterwards, and they cannot even say what happened to us. So there are so many types of trauma. There are so many evidences. There is so much of research about this trauma and trauma-informed care that it is endless. It will take, it itself is a big topic for continuing education, so that we will be empowering ourselves to empower our clients and survivors. Thank you. Yes, you can ask. हाँ बेटा, ये सारा कुछ we are doing for our students. So you should have something in your mind, so that if questions are wrong, right, you have every right to ask. If it is you as per your experience, because you need, today we are here, tomorrow you all have to be here. So you have to be better than us. As I said, जो आपको facilities है ना, in terms of internet and knowledge explosion, हमें नहीं था, हम गरज वाले journal ऊपर वाले पढ़ते थे, है ना? We saw all when we did our PhD, then हम गरज इतना होता था उसमें journals में, हमें sore throat होता था. Whereas you do your research, this review online, so you are fortunate in that way. You can learn a lot, and I expect you to have more knowledge than this generation. So tell us about new things. You can add, you keep on learning, and you can add to it. हमने थोड़ा सा बताया, तो आप उसका हमारे हाँ मैडम हमने ये देखा, हमने ये पढ़ा. That is how you have to add as youngsters. बताइए कोई भी. You can add. It is not only matter of having question. You can add to it whatever we all spoke. Whatever I spoke within 2 minutes only, I finished. बताइए. No, because it was repetition of the things. Maybe you have understood everything, and maybe you know more of it. Thank you very much.
Ma'am, I have one question. Can you please tell?
We have to open presentation.
No, ma'am. I have one question. Ma'am, can you please tell everybody that, give some tips that how to deal with the day-to-day stress life?
What is it?
Stress. How to deal management?
Stress management.
Yes, ma'am.
Stress management. It's a big topic. Stress management itself is a big topic. You have to first thing. मुझे लगता है कि we have to analyze why we are stressed. First thing, we have to identify the source of stress. When we will be able to find out what is stress, why we are stressed, then we can, as I said, we have to talk to the person who is expert in dealing with stress. I will talk to my mother. मेरी माँ कहेगी मैं जो कभी नहीं था वो मुझे चांटा मारेगी. आपका किस चीज़ का खाना भी है, कपड़े भी हैं, घर भी हैं. So why you are stressed? So we have to talk to health. So nowadays it comes mental health. Take help if you have some stress. Take help from the people. So first thing for me, I am as layman. As layman, I will take stress management is first identify why you are stressed. You identify yourself. Then you discuss with those people who can help you. Don't discuss with unnecessarily people who will make you more stressed. Those who will make you, मुझे मेरी नानी को था तो वो मर गई. So you don't have to talk to those people who will make you to die. You have to talk to the people who will be able to help you. You have to talk to the professionals about your health. First is easy way to identify it. So why you are stressed? Because there are so many chemical changes that are related to the stress. So you will not be able to do anything if you are stressed. If you will not be able to do your day-to-day work, because we have to adjust ourselves with the routine. Without doing our routine, we cannot survive. Whatever responsibility we have. So if we are stressed, we will have no interest in doing the day-to-day things. If we will have no interest in doing the day-to-day things, so we will not be doing anything and we will be like, it's the worse than the vegetative life we will have. So we have to first identify and then talk to the, mere hisab se, talk to the professional person, not to the layman, not to the person who will make you more stressed. That's.
And ma'am, last, can you please give the few tips for good mental health? I think, yeah, for good mental health.
I am a community health nurse. So, community health nurse. So, ये जो लिखा है कि accept yourself as you are. Don't compare yourself. For me, whatever hardships, whatever weak points I have to accept. Sometimes I say, it was my destiny. Whatever has happened, it is my destiny. That is what Neelam ma'am said, value system. Value and religion. If you will believe in any of the religion, that is whatever has happened, that is your destiny. So I will not be stressed if I will just say this. Because anything has not happened because of me. That is mentally healthy. You accept first thing mentally healthy ka hai na kitab sab kitabon pe. Ki you accept yourself as you are. So don't be jealous of other sexes. Don't be jealous of isko zyada hai mujhe kam hai. Then I will be not mentally healthy. कोई काम पास होगा मेरे से ज़्यादा marks होंगे, I will be jealous, I will be not mentally healthy. So some people will have lot of gold, lot of property, I will be, मेरे पास उतना gold, उतनी property नहीं है, then I am not mentally healthy. So whatever you have, first think of psychiatry, first think of mental health is only one principle, उसी पे सारे principles हैं, accept yourself as you are, that's all. That will make you mentally healthy, that there is nothing like any other thing. Then you read. हाँ बेटा, इनको माइक दीजिए, इनको माइक दीजिए.
Things are published in books regarding this mental health. I want to know from your personal experience. So that is what my question is.
That is when we are, Dr. Harpreet, Dr. Neelam, when we are talking, no. It's a self-management. That is what she has concluded. Let us have a big hand for her.
Ma'am? Madam? Ma'am, with your permission, can I just answer her? Ma'am? Can I just add to it? See, ma'am has explained to you in a very simplified manner what you asked for the word stress. The stress is not a word that comes on its own to us in our day-to-day life. It's all what we create attention for ourselves without using a common sense. And if we are able to understand our own transactional analysis and idea of communications and how we can counsel ourselves to solve every problem that comes into our life, then there won't be any stress. And problems are not created by God or by anybody, it's a man-made problems. So this is how we should understand how to live in a society and understand what stress is coming to us, how we can drive away the stress.
Transactional analysis.
It's very important.
You know how much is hidden, how much others know about you, how much you know about yourself. That is the...
Like I am okay, you are not okay. You are okay, I am not okay. We have to use the 4 steps of transactional analysis.
You read those windows.
And those Johari windows are very important for us, what we learned in the first year of psychology.
Johar's
Windows.
You read the Johar's windows, you will come to know how much you know about yourself, how much others know about yourself, how much is blind, how much is open. Then we have to read a lot about the psychology to adjust with ourselves. Nowadays people are talking of, you know yourself. You take care of yourself, don't bother for others. है ना? इस पे focus करें हम. I have to be better version of myself. What I was yesterday, I have to be better version. I don't have to be like ABC. So those, and you read about this Johar's windows, so that you will come to know about yourself. You will come to know what others know about yourself, what are blind and what are open things. So some of the adjustment, there are so many adjustment theories there. So we all, it's not only you.
It's Roy adaptation theory.
We have to read a lot about the this, how we will be able to adjust, how, and those adjustment theories will help you to release your stress. That is, whose theory was that?
Roy.
Roy came along. Right? Stress management kiski theory?
Another thing is regarding the mental health tips. Ma'am, unless we are not on the motivation skills, we are not on the encouraging spirit of our own self, we cannot have mental health peace.
Madam, we are both community health nurses.
No, I'm a med surg person.
She is then mental.
I'm a medical surgical person, but we need to understand that
We don't have to compare with anybody. That is the khanda. That is the thing. We don't compare yourself with anybody. You will be stressed.
Ma'am, thank you so much.
Don't
thank you so much.
yourself with others.
Ma'am, I think thank you so much. Ma'am, we are running out of time. I think ma'am will wind up. Yes, ma'am. And now we have the campus tour. We are planned for the campus tour. So the person who is going to wish for the campus tour.
Hello. As we are asking that stress management, the first thing, the cause of stress management. I am also community health nurse, but from the experience, I would like to say the main thing, जब हम कहते हैं कि किसने बोला, अच्छा ऐसा बोला, मुझे बोला, क्यों बोला, कब बोला, so it is a more dangerous than Ebola virus. So this is the cause of stress, more stress. उसने बोला, कब बोला, क्यों बोला, किस लिए बोला, अच्छा ऐसा है, ऐसे बोला. So the acceptance comes first, then comes the adjustment. When we accept the person, accept the things as it is, then there is no problem. And meditation helps a lot in stress management. This is the main thing I would like to say. Thank you.
Thank you, ma'am. Thank you so much. I understand that all of us must be going through many things in our lives, and we are having many questions, but don't worry. Tomorrow we are also having sessions, so tomorrow we'll continue with 2 sessions and 1 panel discussion. There you can ask your questions because now we are running short of time. So now our vehicle are waiting outside. You can go to our campus tour, and after that we are having a cultural event for all of you here only. At 6:45 we'll start with our cultural event. And one more last but not the least announcement is, tomorrow morning we are going to have a meditation. It is not compulsory, but you people can join us at 6:45 a.m. in IB Theatre. Thank you. Thank you so much. Have a blessed evening. See you all tomorrow.